السلام عليكم ورحمة الله وبركاته. حياكم الله مرة ثانية وفي العافية يا رب وتقبل الله طاعتكم. R2 R5 إن شاء الله يكون القهوة وياكم علشان تصحصحون للمحاضرة الجاية. It's my privilege to introduce Dr. Fay Alajeil, our reference in osteoporosis in primary health care. Dr. Fay is a specialist in family medicine with the CGB International. She is a trainer in the Kuwait Family Medicine Residency Program and member of Geriatric Medicine Program Committee. She has keen interest in osteoporosis and has completed the HOPE 1 and 4 programs for the management of osteoporosis, as well as the Obesity Academy Master Class with Lerna and Scope Institutes. Please join me in welcoming Dr. Fay Alajeil.
يعطيك العافية دكتور مشاري. Thank you very much. Good afternoon, everyone. I hope you had a great break and benefited from the review course up until now. Inshallah, this lecture will be focused on reviewing the Kuwait Osteoporosis Guidelines and application on a few cases. So I will not go over any theory, but I will go over the guidelines specifically tailored to our primary care. Okay? Yeah, that's one second, please. Okay. Okay. Inshallah, after this lecture, it will be more clear to all of you how to interpret FRAX results. I'm having problems with how to read the DEXA scan and the vertebral fracture assessment report, medication prescription, and if possible, follow-up. Okay. As I said earlier, we're going to go over the guidelines and a few cases. But please, before we start, if you can kindly scan the QR codes available. The first one is for the guidelines, and the second one is for the FRAX Kuwait model. Please keep them close to you. We will use them, and we will use the guidelines to follow our management plan. Okay.
Sorry to interrupt, doctor. There is a camera blocking. Okay, now it's clear. Yeah.
Yeah. Sorry, I forgot about it. Okay. Okay. So, as you might all be familiar, this is the FRAX tool, the Fracture Risk Assessment tool for Kuwait. It is, you can access it through, if you just put on Google FRAX Kuwait and it will show, or through the QR code that is available on the guidelines. It is basically a calculator. It calculates the fracture risk of the patient in the next 10 years and the major hip fracture also. So as you know, it is composed of 11 questions. Most of them are 7 questions are dichotomous, which means it's either a yes or no answer, in addition to the patient's age, gender, BMI, and if available, the result of the DEXA scan. Okay, so it is similar to the cardiovascular risk calculation tool. It's just a tool to calculate the risk. Okay, so moving on to the algorithm, the guidelines. It might be a lot, but we will take it into sections, okay? First of all, as you all know, osteoporosis is a silent chronic disease. Because it's silent, we need to screen for osteoporosis before the problems and the complications of osteoporosis occur. And our screening population are postmenopausal women and men aged 50 and above. So once you have a patient that is postmenopausal woman or a man aged 50 and above, he is eligible to screen. You will ask the patient from the beginning a question, whether the patient has sustained a fragility fracture or no. So what is a fragility fracture? A fragility fracture is a fracture that occurs to the patient without an external force, or it can also be defined as a fracture that occurs to a patient because after falling from height, for example, the patient is at home and there was a wet floor and he slipped or she slipped and they fractured their hip. This is a fragility fracture. If the patient tripped with a wire in their house and like he fractured his spine, it is also considered a fragility fracture. However, fractures that occur after car accidents or patient fell from a height of more than his own height, this is not a fragility fracture. So it should be a fragility fracture of the spine, of the hip, or two or more other sides excluding the scalp, the bones of the hands and the toes and the feet, the whole feet, okay? Distal to the ankle bone. Okay, so if the answer was yes, I have had a fragility fracture in the before like 2 or 3 months of my hip and I was operated, this is a patient that is a candidate for anabolic treatment and they are categorized as very high risk patients. Yani this patient is a very high risk patient. We do not manage these patients in our primary care setting. They are referred to secondary care for anabolic treatment, which I will talk about later, and for a baseline DEXA and VFA scan. We always need a baseline DEXA scan so that we can compare our scans when the treatment is initiated. If the patient was started on an agent, later on we have to compare the bone density. Okay, so this is if the patient has had a fragility fracture. We will move on to the left side of the algorithm. If the patient has not sustained a fragility fracture, so the answer to the question was no, you will apply the FRAX, the tool, the calculator that we talked about. You will put the patient's age, the gender, and you will answer the questions, and according to the percentage that you get of the major osteoporotic fracture percentage, you will determine what to do with that case. But before moving on to this, I just want to explain the thresholds. As you can see in the diagram in the middle, there are 3 thresholds. What is a threshold? It is the level at which treatment should be considered. For example, we have a lower assessment threshold, interventional threshold, and upper assessment threshold. Lower assessment threshold is defined as the FRAX of the patient who have no risk factors. Yani all the answers to the questions are no. And this is called the lower assessment threshold, the green zone, which means that any patient below that number, below that percent, has a low risk of sustaining a fracture in the next 10 years. Okay, so they do not need treatment. The interventional threshold is the threshold, the score at which the patient that was calculated who has had a fragility fracture. So the answer to question, I think, 4 is yes. And this is determined by the intervention threshold. We will talk about it more later. The upper assessment threshold is defined as the intervention threshold plus 20% extra risk of fracture. And this is called the upper assessment threshold. Any patient above this number is considered as a very high risk patient, and they should be treated with anabolic treatment. So they are not within our scope. You will screen the patient, and once you determine that this patient is a very high risk patient, you will refer them to secondary care. Okay, so let's put this into practice. If you apply the FRAX to a patient, for example, he or she is 60 years old, you will look at the chart on the right, and the FRAX was 2.5 at the beginning. You will look at 2.5, and where does it go? Where is the level? Is it between lower assessment threshold and upper, or is it below the patient's lower assessment threshold? So if you go to the chart and you look at 2.5, you will see that this score is less than 3.1, which is the lower assessment threshold. So the patient is in the green zone. The patient has low risk of fracture. You will reassure the patient. You will repeat the fracs in 5 years, or if the patient's condition changes, clinical condition changes. What does that mean? For example, within these, you frax the patient, he was below lower assessment threshold, and then after 2 years, he was diagnosed with diabetes. They have to come back to refrax them so that we can refrax them and determine their new risk. Okay, so these are the patients who are at the lower risk, below lower assessment threshold. If the same patient, 60 years old, comes to you and you frax this patient and you calculate his frax score as 9, you will go to the chart on the right side and you will check where does 9% lies. As you can see, it is above upper assessment threshold. So these patients are in the red zone from the beginning. They will be referred for anabolic therapy in secondary care and a baseline DEXA and vertebral fracture assessment, okay? However, if the patient, the same patient, 60 years old, you calculate the fracs and the fracs is 5, you will see that it lies between the lower assessment threshold and the upper assessment threshold, which means that they are in the orange zone. These patients will be referred to do the DEXA scan, and then they will come back to you. The DEXA scan is used to answer question number 12 in the FRAX tool. It will determine if there is an added risk, okay? So once the patient comes back from the DEXA scan and you have the report, you will reassess their probability. Once you reassess the probability with the DEXA scan report, you will use the interventional threshold as a baseline. For example, the same patient, 60 years old female patient, comes back to you, okay, with the DEXA report, and her fracs was 5. So you will look at the pink column and you will look at number 5 and you will compare it to the intervention threshold at 60 years old. It will be below the intervention threshold. So this patient now is considered in the green zone. They have a low risk and you will reassure the patient, but you will repeat the DEXA in 3 years. If after the DEXA report, you reassess the probability and the patient, the 60-year-old patient, comes back to you with a fracs of 9, you will look at the intervention threshold again, and you will see that it is above 6.5. But if you look at the upper assessment threshold, it is also above the upper assessment threshold. So these patients are diagnosed as a very high risk patient for osteoporosis, of fracturing in the next 10 years. So again, you will treat these patients with anabolic treatment in the secondary care. However, if the patient, the same patient, comes to you, 60 years old, with a fracs of 7, you will look at the intervention threshold, and as you can see, 7 is above 6.5, so it is above intervention threshold, but below upper assessment threshold. They are in the orange zone, and these patients are diagnosed as or categorized as high-risk patients. These patients will be treated in the primary care. They are under our umbrella, okay, with anti-resorptive treatment, which I will talk about. Let's move on. Okay, there are a few FRAX score enhancers. What does that mean? There are some risks in the FRAX tool that they don't have an exact range. For example, the patient is on glucocorticoids, but we don't know what the dose. What's the dose of the glucocorticoid the patient is on? Because in the FRAX we don't have a place for the dose itself. So we have to add that risk according to the patient's glucocorticoid dose. If the patient, for example, is diabetic in the FRAX tool, there is no question that is specific for diabetes type 2. So you will add the risk of diabetes type 2 in 3 ways, as you can see in the first chart. You either tick yes for rheumatoid arthritis, or you will add 10 years to the age, or you will decrease the T-score by 0.5. This is in the last question. For example, if the patient is diabetic and you want you chose to add, to correct for that enhancer by adding the negative 0.5 to the T-score, and the T-score was, for example, negative 2.1, the new T-score will be negative 2.6. Okay. If the patient comes back to you with a DEXA scan of the hip and the vertebra with a discordance between them, which means that, as you know, in the FRAX, we use the T-score of the hip, the lowest hip, but we don't use the T-score of the spine. But sometimes the spine is worse than the hip. So we correct for that discordance by adding to that risk. How? For example, if the DEXA scan hip, the T-score is negative 2.5, and the number L1 to L4 is negative 3.5, there is a 1 standard deviation difference. So you have to add 10% risk to the new FRAX. We will take a look at that in the cases, inshallah. In addition to the third or the other enhancer, which is the recent fracture. If the patient has had a recent fracture within the past 2 years, an extra risk should be added to the FRAX. And this is done for the recent humerus fracture and the recent forearm fractures. And it is according to age also. So you will, after you get your final FRAX, you will multiply by the factors shown here in the chart. We will take a look at a case example, inshallah. Okay, so now you decided to manage the patient. You will start treatment for the patient, but before starting the treatment, there is a very important treatment evaluation that should be done. The patient should be assessed for hypocalcemia because some agents can cause hypocalcemia. So we have to optimize the calcium level before starting the treatment, and we have to maintain it at a good level. We have to check the patient's glomerular filtration rate. We have to optimize vitamin D, and you have to check and advise the patient if they are going for a dental procedure, for that to be done and them to be cleared before starting osteoporosis treatment. The procedures that are important are the deep drilling procedures. So, for example, if the patient is going for a crown or things with deep drilling, these patients should be done with their dental procedure before initiating treatment. Okay, so this part of the algorithm is the treatment part. It is a bit crowded, but we will simplify it. So you will have your initial evaluation, as we said. You will FRAX the patient. You will order the labs, the important labs, including patient's bone profile, thyroid function test, parathyroid test, vitamin D, and urine calcium to creatinine ratio if you are starting treatment. It is very important to check patients' parathyroid hormone level, especially in those patients who have had a thyroidectomy, because some might have a very occult low or calcium, or the treatment might trigger hypocalcemia. So please, we need to check the parathyroid hormone level. So the high-risk patients and the very high-risk patients treatment is divided into non-pharmacological and pharmacological. Non-pharmacological including smoking and alcohol cessation, limitation of caffeine to 3 cups a day, weight-bearing exercises, and measures to reduce risk of falling at home, which is very, very, very important. This includes rugs with loose ends, loose rugs, wet floors, rails for the elderly, rough floors in the bathroom, You advise the patient to have enough lighting for them if they would need to go to the toilet at night. We advise the elderly, if possible, to stay in the ground floor, and shoes that are appropriate for the patient, slippers that have a rough surface at the bottom. The pharmacological treatment, as we said earlier, is to optimize patients' vitamin D. Optimize and maintain. They should be maintained on a maintenance dose, which is the 50,000 international units per month or equivalent, please. Maintaining calcium intake within 1,000 to 1,200 milligrams a day, mostly from the diet. We prefer from the diet rather than from supplements. And 1-alpha is only considered in patients with renal impairment and hypoparathyroid. So we don't give 1-alpha to improve patients' calcium levels. Okay. For the very high-risk patient, as we said, we will refer these patients to the secondary care for anabolic treatment. 2 agents are available here in Kuwait. I will not go over the details, but they are given. Remocizumab is given for a year. Teriparatide is given for 2 years, once in a lifetime, and then these patients have to continue on anti-resorptive treatment. They should not. It's not only anabolic and then no treatment at all. Anabolic agents, they build the bone. Remocizumab has a dual effect. It builds the bone and inhibits breakdown of the bone, but these agents should be followed up with anti-resorptive agents, which are the agents that stop breakage of the bone. Okay, they stop osteoclast. With regards to anti-resorptive treatment, we have 2 agents available in the primary care: the alendronate, which is the oral alendronate, Fusomax, and we have the injectable denosumab subcutaneous injections, which are given every 6 months. The zoledronate, which is the IV form of the bisphosphonate, is available in the hospital setting. It should be given in the hospital setting because it causes an acute phase reactant, and they should be monitored. Okay. We should, of course, monitor the patient. We should follow up the patient. And this is done by repeating the DEXA and looking at the patient's BMD every 2 years. It is very important, and if it's possible to be in the same machine, in the same setting, and if with the same technologies, that would be great. Here we will monitor the changes of the BMD, and we will not look at the T-score when following up the patient, because we want to see the effect of the treatment agents, the medications, on the bone density. We want to see, did the bone density improve or no? If there is a stable BMD or an increasing BMD, this is a sign of treatment success. And of course, if there is no fractures. If there is a decline in BMD or the patient is on treatment but they fractured, this means that the treatment has failed. It did not have any effect on the patient, but we have to rule out the patient's non-adherence, non-compliance to medication, rule out secondary causes, which I will talk about, and if there are any scan issues. If there is, for example, the alignment of the DEXA of the hip or the spine, this can also affect the results of the BMD. Okay, so this is a leaflet that is available that we give the patient with regards to home safety, the side on the right, and with regards to general advice about diet and exercise, alcohol consumption, vitamin D. And this is very useful to be given to the patients as they help to reduce the risk of fracture. This is also a booklet, a calcium dietary booklet that is done by Dr. Nadia Alajeil. It gives the patient an idea of many types of food in the diet and the amount of calcium that is available. It is divided into specific groups of the food, of the diet: fruits, vegetables, nuts, dairy products, and so on. For example, if the patient takes 1 cup of non-fat yogurt, it contains around 450 milligrams of calcium, which is almost half of what the patient needs a day, daily calcium intake. Okay, this is the bisphosphonate that is available in the primary care, which is the oral bisphosphonate, Fosamax. You should advise the patient that it should be taken 30 minutes before breakfast, to swallow with a glass of water, to sit upright for 30 minutes, and if the patient misses the dose, the patient not take 2 tablets together. Because of its prescription requirement, the compliance to this medication sometimes is difficult on the patient, and because of its contraindications, some patients they decide they're not compliant to it, and decide to or favor the denosumab more, which is the injectable monoclonal antibody that is available in the secondary care. Okay, the last part of the guidelines is the vertebral fracture assessment. Vertebral fracture assessment is simply an image of the lateral spine of the patient that is done at the same setting of the DEXA scan. So when the patient is referred to do a DEXA scan, they are asked to either turn to their side, or the machine itself will turn to the side of the patient, and an image of the lateral spine is taken. Basically, the vertebral fracture assessment report shows the shape of the vertebra, and I will talk about this in the first case. So the indications for vertebral fracture assessment is in all women age 70 and older, and men age 80 or older, in a woman and men age 50 and above, who had sustained a low trauma fracture, who come with a historical height loss of 4 centimeters or more, which means that the patient comes to you and tells you, I feel that I became short. My dresses, I'm shortening my dresses or my dishdashes. And if there is a prospective height loss of 2 centimeters or more, this is determined by the patient's record. So you check the patient's record for the past 2 years or 1 year, and you see that the patient has lost 2 centimeters of his height or more. These are the patients who are indicated to do the vertebral fracture assessment. If the patient is on recent or ongoing glucocorticoid treatment, vertebral fracture assessment should be done to them also. So how is it done? Once you refer the patient and you have the form, you just write at the end VFA and VFA, and the technicians will know. Okay, so who are the patients? To recap, who are the patients who should be referred for anabolic treatment? Any patient who had prior vertebral fracture, as we said, they are in the red zone, the red group, prior hip fracture also, multiple 2 or more fragility fractures. So this is the criteria for the very high risk in the guidelines, the part on the right side. The patients who fracture on anti-osteoporosis treatment, for example, they are on anti-resorptive treatment and they fractured, they should be referred for anabolic treatment. If you adjust the FRAX score and it is above the upper assessment threshold, as we said, if you adjust it for the discordance in the lumbar spine, type 2 diabetes, glucocorticoid use, any of the enhancers, they should be referred, and it is above upper assessment threshold, they should be referred to anabolic treatment. The very frail elderly patients should be referred for anabolic treatment. The patients who come with frequent falls, they come with a history of falling several times a year, and they didn't fracture yet, these patients should be referred for anabolic treatment. Okay, just to make things simpler, a clinic form was made that is easy to follow, and it is useful for the clinic. It is divided into parts. The first part is basically the FRAX questions. The secondary osteoporosis points are also listed. Patients with type 1 diabetes, you will tick yes for secondary osteoporosis. Patients who have had bariatric surgery, patients who have osteoporosis imperfecta, hyperthyroid patients, hypogonadism, premature menopause, you tick yes to secondary osteoporosis. Patients with malabsorption, chronic malnutrition cases, for example, Crohn's disease, ulcerative colitis, and patients with chronic liver disease are all considered as secondary causes of osteoporosis. And then on the right side, the very high-risk patients. And then there's a chart for FRAX and DEXA results, the enhancers, the BFA, the labs that should be needed, and the treatment plan. This really may, and this is for the follow-up. It makes the follow-up of the patient much easier, and hopefully, inshallah, soon it will be in the PCIS. Okay. Who also do we refer for secondary care? If the patient comes with a fracture and they are below 50 years, or if the patient comes with a DEXA and they are and the FRAX score indicates risk, they should be referred. Patient with very high risk osteoporosis, as we said, on glucocorticoids, they are not improving, and on treatment, and the patient's condition complicates the treatment. For example, hyperparathyroid patients, chronic kidney disease patients, and patients with malabsorption conditions. If the patient repeatedly fractures with a normal BMD, for example, their bone density is normal, but they fracture, these patients should also be referred to follow up with endocrinology. Okay, now the second part is the DEXA interpretation. The DEXA is basically a report that shows us the density of the bone in the hip and the lumbar spine. Okay, we should always make sure the patient's identity. We should check the type of machine, the alignment, and the FRAX calculation, where we use the T-score of the femur neck, the lowest femur neck. They will come with 2 T-scores. The left and right femurs, we will use the lowest one. And we will also check the T-score of the lumbar spine. We use T-score or BMD when we calculate the FRAX. However, when the patient comes back to you after 2 years with their second DEXA scan, we will only check for the BMD values. You will not use the T-scores because you will not use the FRAX with follow-up. Okay, so the FRAX is only used to screen. Once you determine that the patient should start treatment and they are on treatment and you're following up the patient, you compare BMDs and not T-scores. Okay, so here is an example of part of the DEXA scan. As you can see, there are 2 machines. One of them is the hologic and the other is the lunar. Mostly in Kuwait, hologic is very common, and you can see the difference. For example, if this is not shown, the name of the machine, but most of the time, yes. The hologic, the background is black, while the lunar, the background is white, okay? And they usually come with the values of the left and right femurs. So you will look at the T-score when you are calculating the FRAX or the BMD. But for the sake of this lecture, we're going to use the T-score. As you can see, the left is -1.3 and the right is -0.9. So when we use this to calculate the FRAX, we will use the lowest hip, the neck, which is the left. We will use the -1.3. Okay? Let's move on. Okay, so now we will start with the cases. Each case has a point of discussion, a point to be learned. And with practice, inshallah, you're going to get the idea of it. So we'll start. Please, I want you to prepare your FRAX tool and the guidelines next to you. We will calculate the FRAX, we will interpret the FRAX, we will decide whether the patient needs a vertebral fracture assessment, and the plan, the treatment plan. So again, this is the tool, the FRAX tool, and these are the QR codes. If you haven't scanned them yet. They are here. Okay, shall I move on? Okay, so this is the first case. So basically, I have put the information on the left side. Please just put it in the FRAX calculator and check the FRAX score. They are 80. This patient is 81 years old, male patient, Kuwaiti. So make sure your FRAX is based on Kuwait's population. The weight is available, the height. There is no previous fracture. There is no parental hip fracture. The patient is a non-smoker, non-alcoholic. He is not on glucocorticoids, non-diabetic, non-rheumatoid arthritic patient, and has no secondary causes. The T-score of the neck here is negative 2.3, and the T-score of the lumbar 1 to L4 is 0.8. Let's put a poll now, and I want you to calculate the patient's FRAX. Make sure you put, for the question number 12, you choose the T-score, then the drop-down menu. Okay. So 5.4. So yes, it's 5.4. So how do you interpret this percent? 5.4. It is, if you put it on the chart itself, it is below interventional threshold. So you go to the patient's age. The patient's age is 81, correct? Is there an 81 on the chart? No, but you will take the average. The patient's score is 5.4. You will look at the pink column and you will interpret. Is it below that number? Yes, it is below. So the patient is below intervention threshold. Would you order a vertebral fracture assessment for this patient? Yes, you will. Why? Because of the age. That's it. Because of the age, you're going to order a VFA. What is your plan? You will repeat the DEXA and VFA in 3 years. Of course, for all patients, the non-pharmacological treatment and pharmacological treatment, which is advice, home safety, optimize vitamin D and calcium. Vitamin D and calcium, as you all know, is the foundation of the bone, the building blocks of the bone. Okay, so here it is. This is the report of this patient. As you can see, you use the T-score of the femur neck, negative 2.3, as you guys did, and you will look at the lumbar spine. The lumbar spine L1 to L4 is 0.8. For the sake of this case, the negative 2.3 is the T-score of the hip, and the L1, L4 is 0.8. Is there a discordance? No. Which one is better? The lumbar spine. So the neck is very bad, negative 2.3, when you compare it to the lumbar spine. So there is no discordance. You don't have to add the lumbar spine to the hip. Okay. And here is the vertebral fracture assessment. It will come in this way. It is a lateral picture of the spine. It is basically, it analyzes the shape of each vertebra. As you can see, the spine is a bamboo shaped. They are squared vertebra, and the shapes or deformations that we analyze are 3. Either it is wedge, biconcave, or crush. Wedge is where the anterior part of the spine is decreased, the height is decreased, okay? Biconcave is when the center is decreased, and the crush is when the whole spine height is decreased, okay? And they come in percentages. I will discuss this in another case, but as you all can see, they are all normal. Okay, case number 2. This is a 77 years old female Kuwaiti, weight is 73, height is 148. So the risk here is the patient has a parental hip fracture, so you will tick AS, and the patient is diabetic, so you will tick AS for the rheumatoid arthritis. Okay, so if we can have the poll, please. There is no DEXA scan here. I have not put a DEXA. The patient came without a DEXA scan. Okay. So for number 12, you will not put anything. And for number 12, you will put it in the, you will use the first one, select BMD, so that no value is used. Okay, so above intervention threshold, let's see. Above upper assessment threshold, the patient is very high risk. Why? The patient has a parental hip fracture and the patient is diabetic. These give the patient a very high risk. Once you calculate, the frax is 17% and the patient is 77. So if you look at the patient, it is above upper assessment threshold. So this patient is a candidate for anabolic treatment, and the patient has to do a baseline DEXA and BFA, as we don't have a report for him. So this patient you would refer for secondary care or treatment. Okay. The third case. If we can have the poll. Okay. Yes, this patient is a candidate for vertebral fracture assessment because the patient has had a previous fracture. So as we said, any low trauma fracture patient, they have to be referred for a vertebral fracture assessment. So let's see. The patient calculated frax is 6.3. You have to multiply by the factor 1.16. That will increase his risk. Why? Because the patient has had a previous fracture, which is recent. If you can see, it happened in December 2022. So it is between the 2 years window. Okay. So the new frax is 7.3. And if you interpret this frax, it is above intervention threshold for this patient. And this patient is a candidate for anti-resorptive treatment. Okay. And the T-scores here is -1.3 and -2. There is no discordance more than one standard deviation. The difference is 0.7. So once the difference is 1, a full 1, you will add the 10%. For example, if the L1, L4 here was -2.3, so there is a 1 standard deviation difference that you might add, okay? So this patient is a candidate for anti-resorptive treatment. You will treat this patient in primary care in your clinics. And this is the report for this patient. Again, the left and the right femur necks are shown. We have used the lower one, -1.3, which is worse than -0.9. Is there a discordance? No. The L1 to L4 T-score is -2, and the left femur neck is -1.3, so the difference is not 1 or more. Okay. Okay. Now, denosumab is available in primary care. It is an anti-resorptive agent that we use to treat patients with osteoporosis with an intervention, with a frax of a bit between intervention threshold and upper assessment threshold, the high-risk patients. It is an anti-resorptive, fully human monoclonal antibody. It is the first-line treatment in International Osteoporosis Foundation guidelines for postmenopausal women. It is very simple. It's a subcutaneous injection similar to insulin injections given every 6 months for 5 to up to 12 years with no drug holiday. The patient does not stop it. It has a safe profile with patients this is an advantage with the patients who have renal failure or patients who are taking medications for rheumatoid arthritis. The side effects, however, that could happen is diarrhea, dyspnea, hypocalcemia, which is very important. This is why we have to check the patient's calcium before starting treatment for these patients. And of course, patients who have had a thyroidectomy, check patients' parathyroid hormone level. Let's move on to case number 4. Please, if you can calculate the patient's frax, and if we can have the poll. Okay. Okay, ليش? Would you correct for previous fracture? Okay. As we said, previous fractures, if they were within the past 2 years, we would add it as enhanced. We would correct for it. But this patient has had a fracture in 2017. So there isn't any imminent fracture. In 2024, so this is more than 2 years. So you will not correct. However, you will tick yes for the fracture. Okay. Okay. So the patient has had a fracture. You will tick yes. The patient is diabetic. So you will tick a yes for the question about rheumatoid arthritis. Is there a discordance between the femur neck and the spine? No. The femur neck is worse than the lumbar spine. Okay, let's see. So the patient's frax is 13%. It is above intervention threshold. So this patient is a high-risk patient. You will treat this patient with anti-resorptive agents in your clinics in the primary care, and you will order a VFA for this patient as the patient has had a fracture before, and the patient is also more than 70 years. Of course, you will repeat patient's DEXA and BFA in 2 years. Again, always advise safety, vitamin D, and calcium. This is a baseline for all patients. Okay. So again, this is the DEXA report. As you can see, for this patient, we only had the neck. We're not sure even which neck it is. It's the left neck. So it is negative 1.9, and the lumbar spine is 0.1, negative 0.1, and there is no discordance. Okay, so this patient has started on anti-resorptive treatment, and if you just look at the date, this was done in March 2021. Okay, the hip and the spine. She came back, okay, in a year and a half, almost a year and a half, and she has done the DEXA scan by herself, and she came for follow-up. We have to check the improvement or the response of the patient to the treatment by looking at these 3 sites, starting from the best to the worst, what I mean that the medication works best on the lumbar spine, followed by the total hip, and then the femur neck. The lumbar spine BMD was 1.04. When she came back, it was 1.119. Is there an improvement? Yes, the patient has responded to treatment. So this is a treatment success. Okay, moving on to the hip. We will, as we said, I'll go back to, you check the total hip first. The total hip BMD and not the T-score was 0.724, okay? When she came back in December 2022, it was 0.849. Is there an improvement? Yes. So here you will say that this treatment is a treatment success, and the patient should continue, even if the BMD of the neck was lower, okay? So this is a case of follow-up. You follow up the patient by comparing the BMDs in their reports and not the T-scores. Never look at the T-scores when you follow up the patient. Okay, case number 5. If we can have the poll, please. So the risk factors here is that the patient is diabetic and the patient has chronic back pain. So would you order a VFA? Okay, if we can have the poll, please. Yes. Yes, you will order a VFA. Why? Because this patient has chronic back pain. When this patient came to me, she did not have a DEXA report. But this patient is 65, so we ordered a VFA also because of her chronic back pain. She has been having pain for years, and it was not investigated. And there was no explanation. Okay, let's see the results. Yeah. So the FRAX was 6.3% when you calculated it, but there is a discordance between the neck and the lumbar spine. Which one is worse here? The lumbar spine, negative 3.6. How far is it from negative 1.9? You will subtract 3.6 minus 1.9, you will get 17. Sorry, 1.7. And how are you going to interpret this? You will put 1 and then 17. Okay. The difference is what you will add to the FRAX. So as we said, every 1 standard deviation, you add 10%. So there is a difference in not just 1 standard deviation, a little bit more than that, which is the 0.7. The difference, it's a standard deviation and 0.7 of a standard deviation, and this is how you add it, okay? And then you multiply by 7.3. You get 7.3. You will interpret the 7.3 on the chart, and if you see for a 65 years old, it is below interventional threshold. However, we have asked for a VFA, and I'm going to show you the results, okay? As you can see, this is the discordance, negative 3.6 and negative 1.9. The lumbar spine is much worse than the hip, the left and right hip. And this is her vertebral fracture assessment. Okay, so now when you get a report like this, as we said, we have to look at all the vertebrae, okay? And we have to interpret the shape of the vertebra, the shape of the deformation there. For example, if we go to T8, you will see that, you can see that it's a biconcave moderate. What does that mean? There are levels, percentages or severity of the deformation. Look at the left side of the slide, please. If the percentage of the biconcavity, which is here, or any other deformity is less than 20%, it is normal. For example, T7, L1, they are all normal because the percentages are below 20, okay? If the percentage of any of these deformity was 20 to 25%, this is considered as mild. Moderate is between 25 to 40 to less than 40%. Severe is 40% and above. Moderate and severe are candidates for treatment. If you have more than one moderate, you should refer this patient for anabolic treatment. If you have one severe, you should refer this patient to anabolic treatment. If you have one mild, two moderate, you should refer this patient to anabolic treatment. If you have just one mild, no, the patient is okay. Okay, so as you can see, the fractures were in T8, L2, and L4, crush moderate. So you go to the crush, it's 25%. Okay, and if you go to L2, wedge moderate, so you go to the wedge, 32%. Okay, so this patient is a candidate for anabolic treatment. You will refer for secondary care, even though the frax was below intervention threshold. Okay.
Sorry, Dr. Fay, for interrupting you. 5 minutes remaining.
Nah.
5 minutes.
I have 2 cases left. Okay, if you can answer the poll, please, and if you can interpret the frax result. So the risk here is that the patient is on glucocorticoids, 10 milligrams. Okay. If we can have the poll, please. Or you need more time? Okay. Okay, so in this case, there are 2 enhancers. First of all, the prednisolone 10 milligrams, and there is a discordance. So you have to correct for these 2 risk factors, okay? And I'll show you. So there are 2, so the first correction is for the prednisolone. No, the first is for the discordance between the lumbar spine and the neck. So if you can see, there's a discordance between them of 1.6. So this is 1.16. So the frax that you got, you will multiply by 1.16, and then you will get a frax score. Once you get this frax score, you will multiply by the factor of the prednisolone 10 milligram, which is a high dose. So you have to multiply again. So the final frax is 6.4, which is above upper assessment threshold for this patient. Will you order a VFA? Yes, because this patient is on the glucocorticoids. The patient is a candidate for anabolic treatment. You refer these patients for secondary care. Okay. Case number 7. This is the last case, I think. So there are 2 risk factors, please. Diabetes and rheumatoid arthritis. And you will come to patients who do have these 2 conditions, diabetic, which is very common, and rheumatoid arthritis. Okay, let's have the poll, please. All of the above. Yes, it's all of the above. Why? Because I'll show you now. As you know, as we discussed earlier, to correct for diabetes, you either tick yes for the question asking for rheumatoid arthritis, or you will add 10 years or to the age, or you will decrease the T-score by negative 2.1. For the sake of this case and how I answered the frax in this case, I started first of all of adding the age. If you add 10 years to the age and you tick yes to the to rheumatoid arthritis, you will get a score of 9.9. This 9.9 you will plot on the chart as when the patient is 83 years old. You will not plot it as if the patient is 73 years old anymore. Okay? This is one way. The other way, but for correcting for diabetes, is that when you add 0.5, negative 0.5 to the T-score. So the patient is 73 years old, you ticked yes for rheumatoid arthritis, and you added negative 0.5 to the final T-score. So your new T-score is negative 2.1. And by that, you will get an 8.1 frax, final frax. In either way, you will get a frax of below intervention threshold. So the first one you will plot by at the new age when you added the 10 years to the for diabetes, and the second one you will plot at 73 years of age, which is 8.1. Okay, and this is when you added a negative 0.5 to the T-score. You will order a VFA for this patient because the patient is above 70. And again, you repeat the frax and DEXA, the DEXA and VFA in 2 years, interpret the frax, advise safety and vitamin D and calcium optimization. Okay. This is a new calculator, fraxplus.org. It puts into consideration all of the enhancers. You can check it if it's convenient for you. It might be useful. And we came to the end of this lecture. I hope it was informative. If you have any questions, if you have any cases you want to discuss, you can send them to me. You are more than welcome.
يعطيك العافية دكتورة في. Thank you for your wonderful and informative lecture. For me and also for the residents, I'm sure you made the difficult topic accessible and easy to understand for all our residents. We truly appreciate that. Please, Mr. Mustafa, keep Dr. Rafay sharing her slides because there is one a question to be discussed in the case.
Yes.
إذا تسمحين دكتور رفاي case 1.
Case 1. لحظة الحين شلون أرجع؟ Shall I share my slides again?
Yes, please.
Is it? You can see it, sir?
Yes.
Okay. Case 1.
Okay. I have one question. The doctor he asked about if DEXA available. Do we calculate a flags without DEXA first? That the check of patients in green or orange or red zone regarding the assessment threshold?
No, if you already have it available, you take it into consideration. Okay, so you take the T-score of the lowest female neck and you interpret it in the facts, and then you do the discordance if it was available.
Okay, clear. What about case 7? Why we add 10 years to get to the age? Can you really explain to the participants?
Yes. As we said, there are 3 ways to correct for diabetes type 2 in the frax. As you know, the frax tool has no specific question for diabetes. So you either answer this, the patient is diabetic, by ticking yes for rheumatoid arthritis, by adding 10 years to the age, or by decreasing the T-score of that patient by adding more 0.5 to the T-score. So in this case, the patient is already he has rheumatoid arthritis. So of course, you're going to tick yes to the question asking if the patient has rheumatoid arthritis. So what do we do with the diabetes? How do we add that risk? We add it by either adding the age or by adding negative 0.5 to the T-score of the female neck. So that's why we added age, 10 years, and then we plotted a new frax when the patient is at that age, at 83. The patient is 70, you will add 10 years. they will become 80. If he's 73 in this case, you're going to add 10 years. Now the patient is 83. And then you use this FRAX to plot it on the chart.
ممتاز واضحة دكتورة. Last case اللي هو case 5. One resident asking, she said, I didn't get the 1.17 baht in this case.
Yes.
The estimate was almost 1.7. So we multiply score by what? If one is
Yes. This patient's FRAX calculated 6.3, correct? We agree? And
Yes.
then there is a discordance between L1, L4 T-score, which is negative 3.6, and the neck, which is negative 1.9. 1.9. الفرق بينهم, if you subtract and نسوي calculation, 3.6 minus 1.9 is 1.7. Agree? صح?
Yeah. صح.
Okay. So الحين احنا قلنا for every one standard deviation between the neck and the number spine, we add 10% of that frax, صح؟ فإحنا we added the 10%, which is 0.1. هذه 10%. الواحد اللي موجود ما يتغير. هذا ال1 ما يتغير. ولكن إحنا we added the 10% for the first standard deviation. هي الفرق اللي هي 1 اللي هي الفرق اللي بينهم، صح؟ بس في a more difference اللي هي 1.7. هذه 7. We have to add that risk لأنه هو مو ريسك صغير. So how do we add it? It's like 7%. ف 1.7. ف 1 standard deviation is for 10%, and that الأعشار السبعة تصير ال7. ف 1.7. أحسها مو واضحة، صح؟ Shall I explain again? الواحد ما يتغير. أوكي؟ دائما الواحد موجود. ولكن الأعشار تتغير اللي هي what's after the decimal. هذا اللي يتغير. فإذا كان الفرق 1، يعني عندنا مثال T score of the neck was 2 -2 واللمبر was -3. الفرق بينهم 1، صح؟ فراح تضربون ب 1.1. أوكي؟ إذا كان الفرق بينهم 2، يعني كان النك was -2 واللمبر سباين was -4، راح تضربون ب 1.2. أوكي؟ إذا كان بينهم يعني it's not 2 standard deviations, it's 1 standard deviation وشوي، هذا إحنا يعني it is for a better more specific frax we add that risk بالأعشار هذه. فاللي يطلع لي أضيفه after the decimal 1.17 1.18 2.35 على حسب 1.35 أقصد، آسفة.
يعطيك العافية دكتورة في.
الله
Last
يعافيك.
questions. To which department you were referred for anabolic treatment?
endocrinology. وتكتبون الريزن osteoporosis for anabolic treatment وتشرحون طبعا.
Thank you,
Yes.
Dr. Fay, for your time and for your explanation. It was a clear and informative lecture. Thank you so much, Dr. Fay.
حياكم الله، موفقين إن شاء الله. وإذا في أي سؤال أي case you are more than welcome.
Thank you.
العفو.